I am Bernard Herschel. Before my retirement, I was the chief of HIV/AIDS at the Geneva University Hospitals. You may call me an AIDS dinosaur who has followed the HIV epidemic from the very first cases in the early 1980s through the triumph of antiretroviral therapies, a triumph unequaled in the annals of medicine. This triumph has its flip side. Younger colleagues are no longer familiar with the opportunistic diseases and the myriad manifestations, hence the idea of these videos. After a short introduction, they will show a series of images illustrating one or several exemplary cases from my files. This sad-looking ox is the animal from which Edmond Nocard, a collaborator of Louis Pasteur, isolated the bacterium which today bears his name. As published in 1888, Notes on the Disease of Cattle in Guadeloupe. If you know French, pause the video a few seconds and appreciate the quality of the description. Nocardia are gram-positive, filamentous, branching and acid-fast. Here we see the gram stain on the left and the delicate web of acid-fast filaments on the right. Nocardia, like mycobacteria, retain acid-fast stains, but they are easily distinguished. Nocardia are long, delicate and branching. Mycobacterium tuberculosis are short and thick, quote-unquote commas, and not very abundant. Mycobacteria other than TB are longer, quote, knitting needles, unquote, thick and often abundant. Nocardia are ubiquitous in nature. Some can be distinguished by the color of their colonies as shown here. Only a few are pathogenic. In HIV, pulmonary involvement predominates, but cerebral, renal and skin disease is also described. It is certainly rare, but statistics are difficult to obtain because Nocardia infections are not considered AIDS defining. The first patient was born in 1933. He had untreated HIV infection with about 300 CD4 cells per microliter and an elevated viral load. He had type 2 diabetes, a history of pulmonary tuberculosis in 1983, treated, a 60-pack year history of smoking with chronic obstructive pulmonary disease, and he was admitted to hospital in March 2004 with increasing dyspnea, cough, and evidence of right heart failure with jugular distension and hepatomegaly. The chest X-ray at admission showed bilateral reticular infiltrates and enlargement of both heli, particularly on the right. In addition, the CT scan revealed bilateral nodules up to 1 centimeter in diameter and emphysema. The bronchoalveolar lavage yielded nocardia. He was treated with HART, ceftriaxone, followed by cotrimoxazole for 6 months with improvement in symptoms. He was a 28-year-old drug user with 35 CD4 cells per microliter. He presented with fever, cough and weight loss. The BLA yielded nocardia and he was treated with cotrimoxazole and improved. The chest X-ray showed a lesion in the left upper lobe which had disappeared after treatment. Case 3 was a 33-year-old man with alcohol and tobacco abuse. He presented with pneumonia, the HIV was positive, and he had 24 CD4 cells. The BLA yielded nocardia. Treatment with cotrimoxazole and ciprofloxacin was started. However, the patient left against medical advice after a few days. He returned 3 months later. Direct examination of a gluteal ulcer was suggestive of nocardia, but he also had positive blood cultures with Cryptococcus neoformans. The CT scan showed multiple abscesses suggestive of cerebral toxoplasmosis, but stereotactic brain biopsy yielded nocardia abscessus. He was treated with liposomal amphotericin B, cotrimoxazole, and ceftriaxone. Nocardia abscessus was cultured from skin, bronchoalveolar lavage, and stereotactic brain biopsy. This is the MRI after 8 weeks of trimethoprim sulfamethoxazole, ceftriaxone, and liposomal amphotericin. Only traces of the abscesses remain. Aspergillosis in HIV/AIDS is rare, 0.35 per year per person pre-heart and probably less than 0.1% now. Pulmonary involvement predominates, but other organs such as kidney, brain, and skin may be affected. This is a complication of advanced immune deficiency. Less than 2% of patients have a CD4 count of more than 100. Treatment is based on voriconazole, possibly in combination with an echinocandin. The patient we present here was an active user of illicit drugs, aged 40. He was a smoker, probably had COPD. He had chronic hepatitis C. He had known HIV infection since at least 1988, but was relatively healthy until 2001, when he was diagnosed and treated for pneumocystis and tuberculosis. In January 2004, he stopped taking highly active antiretroviral therapy. He developed dyspnea, had a weight loss of 10 kilograms, an increase in sputum, which was occasionally bloody. He developed pancytopenia. At admission, he had a hemoglobin of 76, 2.4 leukocytes, and 52 platelets. He had 34 CD4 cells per microliter and a viremia of 5,000. The sputum cultures were positive for Aspergillus fumigatus. The chest X-ray shows a cavity in his left upper lobe, which expanded from July to September 2004. The CT displays the typical appearance of an Aspergillus cavity with debris inside, according to the French, resembling a bell with a clapper. The patient died suddenly from massive hemoptysis. He had several recognized risk factors for aspergillosis in HIV infection. A history of pneumocystis. It is thought that remaining cysts favor colonization by Aspergillus. Advanced immune deficiency, neutropenia. The only risk factor that was missing was prolonged steroid treatment. Bacillary angiomatosis is an uncommon infection due to Bartonella hensella in patients with AIDS or Quintana in other patients. Lesions in the skin are also called epithelioid granulomatosis, and lesions in the liver are also called peliosis. The disease typically involves the skin, but is often generalized. The lesions show vascular proliferation, and the main differential diagnosis is Kaposi's sarcoma. Bacillary angiomatosis presents with flesh to violet-colored tumoral skin lesions. In comparison, lesions of Kaposi's sarcoma are often flat, but may also be tumoral and resemble the lesions of bacillary angiomatosis. A few more examples of lesions of bacillary angiomatosis in the face and the anogenital areas. There are typically a few such lesions, but they may rarely number in the hundreds. Note concomitant chronic herpes simplex. This patient, who had very advanced HIV infection, presented with fever and pain in his heel. The radiograph showed a lytic lesion which was biopsied. The biopsy was stained with the method of Wharton-Starry. With this stain, Bartonella hensela shows up as black, rod-like or coccobacillary elements. Definite diagnosis relies on amplification and sequencing of 16S ribosomal DNA, as well as serology. Doxycycline 100 mg twice daily is the mainstay of treatment. Some experts add rifampin 300 mg twice daily during the first 2 weeks, and the total treatment duration is 3 months. Thank you for watching, and thanks in advance for your feedback. This video is part of a series on opportunistic diseases in HIV/AIDS. If you are interested, please subscribe or click on the latest upload top left.